Good day, Ms. Jade. Good day, classmates. Today I'll be talking about the other medical conditions that cause neurocognitive disorders. So, on the first part of our report, Andrea already have highlighted and tackled about the NCD, which is caused by Alzheimer's disease. Right now, as for me, I will be talking about the other eight as per DSM-5, which identifies eight specific causes, which are frontotemporal degeneration, traumatic brain injury, Lewy body disease, Parkinson's disease, HIV infection, substance use, Huntington's disease, Prions disease, and other medical conditions that can also cause NCD, which are hydrocephalus, the excessive water in the cranium resulting from brain shrinkage, hypothyroidism, an underactive thyroid gland, brain tumor, and vitamin B12 deficiency. So number one, we have the frontotemporal neurocognitive disorder. This is used to categorize a variety of brain disorders that damage the frontal or temporal regions of the brain. And as we all know, the frontal lobe is the most anterior or the front part of the brain. It extends from the area behind the forehead back to the precentral gyrus. As a whole, the frontal lobe is responsible for higher cognitive functions such as memory, emotions, impulse control, problem solving, social interaction, and motor function. As you can see there on the screen, we have neurocognitive disorder with amnesia. We have Mike. He is a divorced man. He had a wife. Now he has a girlfriend. He called her his new brain or the new memory. And then since he's having troubles with his memory, he has the so-called memory notebook wherein he's been writing there everything with date and time, so he knows what's coming up or what's for that day. So for the peak disease, this is a rare neurological condition occurring in about 5% of those people with neurocognitive impairments. This is somehow similar symptoms with Alzheimer's disease, and this course disease lasts up to 5 to 10 years. Early onset occurs during a person's 40s or 50s. So why was it called Peak's disease? So just like to simplify that, we have peak bodies or peak cells. So when they accumulate in the nerve cells of our brain, the frontal and temporal lobe part, they can cause the cells to die. This causes your brain tissue to shrink, leading to the symptoms of dementia. So, ang salaan ani is ang peak cells. That's why it's called the Peak's disease. So this is the diagnostic criteria for major or mild frontotemporal neurocognitive disorder, which of course this can be found in your book and on DSM-5. For our diagnostic features, individuals with behavioral variant major or mild frontotemporal NCD presents with varying degrees of apathy or disinhibition. They may lose interest in socialization, self-care, and personal responsibilities or display socially inappropriate behaviors. Insight is usually impaired, and this often delays medical conditions. So we have the traumatic brain injury. This is more on self-explanatory because of course we already know how it works, right? On the picture on the right side, we have there Junior Su. I'm not sure if I pronounce it right, but he committed suicide by shooting himself in the chest in 2012 at the age of 43. And then later studies by the National Institute of Health concluded that Sue had chronic traumatic encephalopathy, or CTE, a brain disease that also has been found in other disease former NFL players. So basically, or obviously, it's because of the nature of their games. So there's always like repetitive blows to the head, resulting them to have the CTE. So the symptoms that persist for at least a week following the trauma, difficulty planning complex activities, and problems with learning and memory. Those that are greater risk for TBI are teens and young adults, especially accompanied by alcohol abuse or lower socioeconomic class. Accidents, assaults, falls, and suicide attempts are common causes, as is being exposed to bomb blast in combat. So this is the diagnostic criteria for a major and mild neurocognitive disorder due to traumatic brain injury. Just please refer to your book. Next is we have the Lewy body disease and the neurocognitive disorder due to Parkinson's disease. We have Lewy body disease again. So it is actually a microscopic deposits of a protein that damage brain cells over time. The signs of this disorder come on gradually and include impairment in alertness, attention, vivid visual hallucination, and motor impairment as seen in Parkinson's disease. Individuals with NCDLB frequently experience repetitive falls, syncope, or other transient episodes of unresponsiveness. Autonomic dysfunction may be observed, including orthostatic hypotension, constipation, and other urinary incontinence. Hypersomnia and um, hyposmia may also be observed. We have here the Parkinson's disease affects about 100 to 300 people in every 100,000 people worldwide. Stoop posture, slow body movements called bradykinesia, tremors, and jerkiness in walking. The voice is also affected. Afflicted individuals speak in a self monotone as a result of damage to dopamine highways. These are the diagnostic criteria for major or mild neurocognitive disorder with Lewy bodies and the diagnostic criteria for neurocognitive disorder due to Parkinson's disease. So please again refer to your book. You have the human immunodeficiency virus type 1 or the HIV-1. This is very rampant nowadays. So it's actually an HIV infection itself, irresponsible for the neurological impairment. Early symptoms of neurocognitive disorder resulting from HIV, cognitive slowness, impaired attention, and forgetfulness. Affected individuals also tend to be clumsy, to show repetitive movements such as tremors and leg weakness, and to become more pathetic and socially withdrawn. Different expressions of neurocognitive disorder in two categories. We have the subcortical dementia and aphasia. So the distinction between cortical, including neurocognitive disorder due to Alzheimer's disease, and subcortical dementia is important because of the different expressions of neurocognitive disorder in these two categories. We have the aphasia, which involves impaired language skills occurs among people with neurocognitive disorder due to Alzheimer's disease, but not among people with subcortical dementia. So, in contrast, people with subcortical dementia are more likely to experience severe depression and anxiety than those with neurocognitive disorder due to Alzheimer's disease. In general, motor skills, including speed and coordination, are impaired early among those with subcortical dementia. The differing patterns of impairment can be attributed to the different areas of brain affected by the disorders, causing neurocognitive disorders. So, beside that is, of course, the diagnostic criteria for major or mild neurocognitive disorder due to HIV infection. Next is we have the Huntington's disease. It is a genetic disorder that initially affects motor movements, typically in the form of chorea, involuntary limb movements. People with Huntington's disease can live for 20 years after the first signs of the disease appear, although skilled nursing care is often required during the final stages. Only a portion of people with Huntington's disease go to display cognitive deficiency. 42.5% of new Huntington's disorder cases also present with mild cognitive impairment. Neurocognitive disorder due to Huntington's disease also follows a subcortical pattern, gene responsible, inherited as an autosomal dominant disorder. So this is an inherited as an autosomal dominant disorder. Dominant means that a single copy of the mutated gene from one parent is enough to cause the disorder. So a child of a person affected by an autosomal dominant condition has a 50% chance of being affected by that condition via inheritance of a dominant allele. Associated features for Huntington's disease are irritability, apathy, anxiety, obsessive compulsive symptoms, depression, and more rarely, psychosis can all be associated with Huntington's disease and often precede the onset of motor symptoms. Next is we have the neurocognitive disorder due to prion disease. This is a rare progressive neurodegenerative disorder caused by prions, proteins that can reproduce themselves and cause damage to brain cells, leading to neurocognitive decline. So prions are thought by some to have no DNA or RNA that can be destroyed by chemicals or radiation. No known treatment. Prions are not contagions in humans and have only been contracted through cannibalism, causing kuro or accidental inoculations through blood transfusions from infected person. One type of prion disease is the Creutzfeldt-Jakob disease. I'm not sure if I pronounced that right, but to simplify, prion diseases are caused by abnormal prions. So again, that's proteins. um, it caused a number of the diseases in variety of mammals, including bovine spongiform encephalopathy, BSE or mad cow disease in cattle, and scrapie in sheep. So this is the main reason why that this discovery led to a ban on exporting beef from United Kingdom for a number of years because the disease might be transmitted from infected cattle to humans. We have the substance medication induced neurocognitive disorder. This is a prolonged drug use, especially combined with poor diet, can damage the brain and in some circumstances can lead to neurocognitive disorder. This impairment unfortunately lasts beyond the period involved in intoxication or withdrawal from these substances. So, description and its statistics, as many as 50% to 70% of chronic heavy alcohol users show cognitive impairment, and 7% of those with an alcohol use disorder also meet criteria for a neurocognitive disorder. The long term abuse of a number of drugs can lead to symptoms of neurocognitive disorder, including alcohol, inhalants such as the glue or gasoline, which some people inhale from euphoric feeling they produce in sedative, hypnotic, and anxiolytic drugs. The DSM-5 criteria: aphasia, language disturbance, friction, ability to carry out motor activities despite intact motor function, agnosia, failure to recognize or identify objects despite intact sensory function, or a disturbance in executive functioning such as planning, organizing, sequencing, and so, mild NCD induced by drugs with central nervous system depressant effects may manifest with added symptoms of increased irritability, anxiety, sleep disturbance, and dysphoria. So, NCD induced by stimulant drugs may manifest with rebound depression, hypersomnia, and apathy. In severe forms of substance medication induced major NCD, there may be prominent neuromotor features such as incoordination, attacks related to cerebellar damage and motor slowing, as well as medical complications such as hypokalemia and cardiac arrhythmias. Arrhythmias, yes. There may also be a loss of emotional control, including aggressive or inappropriate affect or apathy. So, this is the diagnostic criteria for substance medication induced major mild neurocognitive disorders. So, you can refer that to your book. Now, we are going to proceed with the biological influences. So, we are going to refer to the table 15.3, the genetic factors and Alzheimer's disease. So, does Alzheimer's got a cure? No, there's no cure for Alzheimer's disease, but there are treatments that may change disease progression and drug and non drug options that may help symptoms. Understanding available options can help individuals, of course, living with the disease and their caregivers to cope with symptoms and improve quality of life, which I will be elaborating more on the later part of the report. So, murata og magwonder nga with the technology, we've been, I mean, technology has been evolving, we've been discovering a lot of things, but na naman dyan wala cure ang Alzheimer's disease. So, of course, scientists, researchers, they're still checking first what causes Alzheimer's disease, right? So, ang ilahang nakita dito, again, we're gonna refer it to table 15.3. Genes on chromosomes 21, 19, 14, 12, and 1, they have been linked to certain forms of Alzheimer's disease. The link to chromosome 21 was discovered first, and it resulted from the unfortunate observation na katong mga tao with syndrome, they have three copies of chromosome 21 na instead of duhara. They develop the disease at an unusually high rate. Panel on, yes, this is reports from advisory panel on Alzheimer's disease. More recent work has located relevant genes on other chromosomes. Discoveries indicate that there is more than one genetic cause of Alzheimer's disease. Some forms, including that one associated with chromosome 14, have an early onset. So that's 33 to 60 years old. And then we have the chromosome 19 seems to be late onset from form of the disease that has an effect only after the age of about 60. So some genes are now identified are deterministic, meaning that if you have one of these genes, you're nearly 100% chance of developing Alzheimer's disease. So that's the first thing that again researchers and scientists are looking into. We have the deterministic genes such as the precursor gene for small proteins called amyloid beta, presenilin 1, presenilin 2 will inevitably lead to Alzheimer's disease. But unfortunately, again, these diseases are rare in general population. For treatment purposes, that means that even if researchers can find a way to prevent these genes from leading to Alzheimer's disease, it will only help a relatively small number of people. So we have there the amyloid beta peptides. So si amyloid um, beta peptides, siya ang main component of neuritic plaques in Alzheimer's disease. And its accumulation has been considered as the molecular driver of Alzheimer's pathogenesis and progression. So this has been the prime target for the development of Alzheimer's disease therapy. So, what is not completely understood is how APOE4 causes amyloid proteins to build up in the neurons of people who ultimately exhibit Alzheimer's disease and whether this process is responsible for the disease. One recent study examined the role of high blood pressure in creating amyloid proteins when interacting with APOE4 genotype in healthy adults. The study found that hypertension alone or APOE4 alone did not increase amyloid deposits. However, healthy individuals with at least one APOE4 gene and untreated high blood pressure had the greater risk for amyloid proteins deposits. Also, the higher the blood pressure, the more amyloid proteins deposits were found. And we all know how amyloid plays a big role on Alzheimer's disease. On the other hand, those with high blood pressure under medical control had only slightly higher levels of amyloid deposits than people without. So we have the potential gene environment interactions and development of Alzheimer's disease. All right. So for researchers, they have to also examine potential gene environment interactions and development of Alzheimer's disease. Several studies suggest a few areas of promise. One study found that having the APOE4 genotype was more likely to produce cognitive decline in those persons living in stressful environments, suggesting a gene environment stress interaction. We also have another study that found that physical exercise reduced the likelihood of developing the disease, but like the previous study, among only those without the APO or E4 gene. So most likely, kanang murag, if naka E4 gene, then murag, worry ka a little bit for having Alzheimer's disease in the future. So we have psychological and social influences. So we have, for example, a person's lifestyle may involve contact with factors that can cause neurocognitive disorder. Although few would claim that psychosocial influences directly cause the type of brain deterioration seen in people with neurocognitive disorder, they may help determine onset and course. For example, again, a person's lifestyle, and this may involve contact with factors that can cause neurocognitive disorder. You saw, for instance, substance abuse can lead to neurocognitive disorder, and as we discussed previously, whether a person abuses drugs is determined by the combination of biological and psychosocial factors. In the case of vascular neurocognitive disorder, a person's biological vulnerability to vascular disease will influence the chances of strokes that can lead to this form of disorder. Lifestyle issues such as diet, exercise, and stress influence cardiovascular disease and therefore help determine who experiences vascular neurocognitive disorder and who don't. So, We also have the cultural factors. For example, hypertension and strokes are more prevalent among of Americans and Africans and subgroups of Asian Americans than non Hispanic whites. This may explain why vascular neurocognitive disorder is also more often observed in members of these groups. In an extreme example, exposure to prion disease can lead to neurocognitive disorder described previously as Goro, like parents can be passed on through a ritual form of cannibalism practiced in Papua New Guinea as a part of mourning. Not getting enough of vitamins B9 and B12 in particular seems to lead neurocognitive disorder. And just a disclaimer, this finding suggests that occupational safety, such as protecting workers from head injuries and economic conditions influencing diet, also affect the prevalence of certain forms of neurocognitive disorders. Psychosocial factors themselves influence the course of neurocognitive disorders. So for the treatment, I already have mentioned it before, there's no treatment for Alzheimer's disease. So researchers are closing in on how to use the brain's natural process of regeneration to potentially reverse the damage caused in neurocognitive. So speaking a bit of science, I mean science has since discovered that neurons can actually regenerate using a really unique method if an area of the brain gets damaged. We call this method neurogenesis. What happens is the brain uses a secret supply of neural stem cells and transforms them into neurons without using mitosis. So the goals of the treatment therefore become number one, trying to prevent certain conditions such as substance abuse or strokes that may bring on neurocognitive disorder. Number two, trying to delay the onset of symptoms to provide better quality of life. And number three is attempting to help these individuals and their caregivers cope with the advancing deterioration. A troubling statistic further clouds the tragic circumstances of neurocognitive disorder. In one study, more than 60% of caregivers of people with neurocognitive disorder, usually relatives, have the symptoms characteristics of one or more anxiety disorders. 55% of these caregivers had anxiety and or clinical depression. 37% of the caregivers had depression. I mean, like, you're working, let's just say for example, you put yourself in the shoes of the caregiver, but I mean, they're also a human being, and as a human being's natural phenomenon, of course, you get impatient, most especially if even magani if imuhang relative or family, mura magani ka og malagot or masuko. How much more for these caregivers who's been taking care of people with neurocognitive disorders like Alzheimer's disease. So, kuan siya, it's gonna be difficult on their part. So as a result, clinicians are becoming increasingly sensitive to the needs of the caregivers, and research is now exploring interventions that are easy to disseminate, such as over the internet, to assist them caring in people for neurocognitive disorder. Because it's gonna be a win-win situation. It's gonna be an advantage for the caregiver, kay para at least they are guided, and at the same time, is we can also protect our elderly ones na of course if malagot si caregiver basin niya og masumbagan niya si patient, so ingon ana, but that's why they're having these kinds of interventions. So, biological treatments, we have a substance that may help preserve and perhaps restore neurons. Glial cell derived neurotrophic factor may someday be used to help. Researchers are also looking into the possible benefits of transplanting stem cells, fetal brain tissue, into the brains of people with such diseases. Neurocognitive disorder brought on strokes, sorry, may now be more preventable by new drugs that help prevent much damage inflicted by the blood clots characteristic of stroke. So we have several drugs called co- um, choline cholinesterase inhibitors. We have had a modest impact on cognitive abilities in some patients and include donepezil, aricept, rivatigmin, exelon, and galantamine rimonil. The crane damage, that's Robbins 2006. These drugs prevent the breakdown of the neurotransmitter acetylcholine, which is deficient in people with Alzheimer's disease, thus making more acetylcholine available to the brain. Research suggests that when using these drugs, people's cognitive abilities improve to the point where they were 6 months earlier. So we have the newer drugs are now being investigated for the treatment of Alzheimer's disease. These include drugs that target the beta amyloid plaques, which is what we have discussed earlier, and it is hoped that its advantage will finally provide a positive prognosis for this devastating disease. We have biological treatments again. Ginkgo biloba to improve memory, but other studies may have not replicated this benefit. I actually have heard of this, but I did not know na pwede na siya sa people with neurocognitive disorders. And then the effects of vitamin E have been evaluated. Wala jud siya as in kanang proof nga it had prevent the development of the disease. We had modest slowing and progression of the disease also may be obtained by introducing exercise to the patients, basic exercise. To date, however, no medical interventions are available that directly treat and therefore stop the progression of the conditions that causes the cerebral damage and Alzheimer's disease. Then we also have um, antidepressants. We also have drugs, antipsychotic, and then other researchers are targeting vaccines that would potentially treat. Pero wala guro ni siya napadayon. It's because there's a negative side effect na siya bad negative effect which is serious brain inflammation. So we have biological treatments. More research with humans and animals indicates that there may be several vaccines that could be effective in preventing the damage caused by AB formation and therefore represent the first glimmer of hope for patients and their families. So as you can see, this is the chart. Um, on the chart is cunning red line, that one. Yes, it's the improving the course of Alzheimer's disease with medical and non-medical interventions. So kani siyang red line katong walay medical interventions, and then kaning purple line is na ana. So I mean there's a huge difference, although not really that big, but at least there's difference. And then psychosocial treatments, as you can see, this is a resident of assistive living facility practices cognitive stimulation using one of the several computer-based systems. We have psychological treatment, teaching communication skills, just like similar to programs with persons with autism spectrum. And then we have the psychosocial treatments, um, as what I've mentioned before. So, moto ni siya tong when caregivers may be kanang above na their patients. So this can also be used to help both of the caregiver and the elderly person with neurocognitive disorder. And then we have the prevention. So one major study conducted in Sweden where socialized medicine provides complete medical histories of all residents look at many risk factors. So basically, murag ang ilaharang ko diri is just control your blood pressure, do not smoke, and lead an active physical and social life. And then summary, to date, there is no electric treatment for irreversible neurocognitive disorder caused by Alzheimer's disease, Lewy bodies, vascular disease, Parkinson's disease, Huntington's disease, and various less common conditions that produce progressive cognitive impairment. Treatment often focuses on helping patients cope with the continuing loss of cognitive skills and helping caregivers deal with the stress of caring for affected individuals. Thank you very much.